So when we reached the conclusion as a large employer that we really needed to change the covenant between how we bought our care, how we paid for it, and how it was provided. And we needed to do that with the people who provided the care and stop throwing these things over the wall at them, right? These pay-per performance stuff that we were doing. I mean, we weren't getting anywhere with that, right? So we reached out to the 4 primary care societies that should be delivering comprehensive care if we paid them to do that, but we pay them to do episodic care. And we said, we would like to change the covenant. I sat in this room. It had 47 large employers plus TRICARE of the Fortune 100, right? I sat in this room with all of organized primary care, the leadership of the AAFP, the ACP, and we said we want to change the covenant. And the AAFP guy said, well, we have had a look at ourselves, and we think what you're paying us to do is also stupid, and we think it needs to change. We completely agree with you. We call it the future of family medicine, and, you know, we think you should be buying comprehensive care from us, not episodic care, right? And the ACP said, we have this plan we call Advanced Medical Home, and we think that is a better way of doing it. The pediatricians raised their hand and said, we've been doing this for 40 years. Nobody's listened to us. You know, it's really simple, you guys. Just think about it in terms of business. It's moving from a care in which there was no project manager to care where there is a project manager. You know, we're going to have data. We already are beginning to have data because there's electronic medical records that are going to happen. We're going to have clinical data. We can integrate that with the claims data. You know, why would you not want to tell the healthcare company that you're dealing with or the broker that you're dealing with, give me a project, give me a plan, give me a product in which I have a much better sense of what's going on, you know, with my employees? We do. I mean, we've made it really clear to the buyers of care that we're migrating to this model, you know, and if you don't have a product to sell us by a certain time frame, you know, we're going to buy something else from somebody else, right? In the communities where we have large employee base, we've been working with our hospitals, we've been working with our providers. Many other large employers are doing the same, Boeing, Dow, others. And in the Mid-Hudson and Vermont, where we're a large employer, I now have 44 to 50% of my employees in a medical home. I mean, here you guys are really lucky because you have, you know, Bellen stepping up to try to do this already, right? I mean, it's great. So at any rate, we agreed, the buyers and the providers agreed that we were going to change the covenant. We, the buyers, told the providers, give us a set of principles that you all agree on, all of your organizations, not one by one, but all of your organizations agree on a set of principles upon which we can change the covenant. We're going to leave the room. We, the buyers, are going to leave the room. You, the providers, because it's at the end of the day, your practice is your business. You give us a set of principles. This is the principles they gave us. This is the joint principles of the patient-centered medical home. It's really, really powerful. It's really, really powerful because it's the first time we've had a set of principles that we've all agreed on. It's been endorsed by the House of Medicine. It's been endorsed by all of the House of Medicine. It's been endorsed by the American Academy of Medical Colleges, etc. And we, the buyers, the Fortune 100, we, the buyers, have agreed this is the covenant we want to change, right? So this is the kind of care we're talking about. We're talking about superb access to care. That would include email, portal solutions, right? That would include open access, flexible schedules, weekend hours, right? I mean, my employees, 26% of them could access their primary care doctors after hours. What does that mean to me? It means to me that the rest of them, when they need care, go to the emergency room. Is that a value proposition for me? I don't think so. You know, where we have this level of care, where we pay, where we deliver this, where we have our employees that can email their doctor, and we have 38,000 of them now that we can do this with. We're building them in all of our communities. We've seen a 28% reduction in face-to-face visits. I mean, is that a proposition for us in terms of productivity? Do we love that? Do my patients love that? You betcha. You know, so we've designed a system where the only way, you know, when you go to your benefit folks and you tell them, you know, the only way the system pays the doc money is if you face them at the window, right? It's as if your banking services, the only way that anybody paid for the banking services was how much time you spent with the teller. I don't care how much time I spend with the teller. I care about the interest rate the bank gives me. I care about the services they give me, right? But that's not what we pay for in healthcare. We pay for only the amount of time that our people face the teller. Is that a dumb way to buy? And are we the ones buying it? You betcha. So we're really talking about changing access, and we're going to have the tools to do this, right? I mean, you now have technology that's available from banking and other things that's migrating to healthcare, and you have the tools, and, folks are stepping up to that to deliver that tools. Demand it, demand it as buyers. Patient engagement and care. In Philadelphia, we were part of a pilot there, and one of many, right? But we saw a 16% reduction in cost there. But we saw an 11% increase in medication costs there. What does that mean to me? It means my patients are engaged and they're taking their medicine. I mean, a huge overall savings. I mean, when I survey my patients with chronic diseases, as you probably do, and you find that oftentimes half or less of their meds are even taken. There's no engagement, right? The system is only if you face the teller at the window do you get paid. So there's no process plan in place. I mean, we wouldn't tolerate that with any other industry. So, when you get the patients engaged, when you really center the care around them, great things happen. There is technology now. There's information. It's going to transform their world. Information technology will do for Mark's brain, for the docs in this room's brain, what X-ray's done for their vision. I know. I've seen it. I happen to be the president of Accure, the company in Denmark, and it's about 10 or 15 years ahead of us. I mean, it's completely transformed how they interact with their patients, how they think about the care, and it delivers information to them that's actionable at the point of care. It's immensely powerful. The likelihood that they can make a mistake in medication management anymore is really difficult. I mean, the kind of communication that you have with your banks, my Danish employees have with their doctors, right? I mean, it's really changing the world. In Denmark, 78% of the encounters that my employees have with their doctor are now asynchronous. They're now remote, right? In Denmark, we've gone from 155 hospitals in 10 years to 21. 26,000 beds to 4,000. Ambulatory conditions are treated, funnily enough, ambulatorily, right? As outpatients, not warehoused in hospitals. Hospitals are not only expensive places, they're dangerous places. They're places you don't want to go. So the healthcare system of the future, the system that we're envisioning happening, is no longer primary care as a food chain for the hospital. It's primary care as a place to keep your patients out of the hospital. It's a huge shift. It's a huge shift in a $2.7 trillion industry that doesn't want it to shift. We as buyers have to demand that shift. We can't survive on the trend line we're on. We can't survive. You won't have any money in a few years to fund your schools. So we're going to go from care that's uncoordinated to care that's coordinated. So no longer does somebody with a chronic disease go in to see a primary care provider and they write out a script. They write out a plan. They coordinate with all the specialists that need to see that patient. There's a team approach to care. It's phenomenally different delivery system, and it really, really, really works. You all know you want that, right? I mean, you want that for all of you have had mothers or folks where they've had 4 or 5 different, and nobody's coordinated except for you. The only coordination system that existed was the back of your Toyota car, and in the trunk, the box that you carried their records around in, right? So, it's possible now to coordinate care. I mean, systems are doing it, right? Somebody's in charge of that. That's the comprehensivist. That's the person who should be doing that. So in the world of medicine, the rest of the world is a bit foggy here, but there's a big branch between various fields of medicine. There's a group of medicine, family medicine, for example, family practice would be an example of that, who should be trained to be comprehensivists. They should be trained to handle everything and coordinate and hand off and be the quarterback on the team, right? If we paid them to do that rather than to do. And then there's partialists who get really good at a part of the body, who focus on a part of the body and do good knees, and but I mean, unless there's something pulling it together, it just goes amiss, right? So it's team-based. When I go around the country and I see these medical homes, it's much flatter. It's not just about the doc. It's about the diabetic educator. It's about the behavioralist. It's about motivation. It's about medication management. It's team.